So the question we're gonna read is on nasolabial cyst doesn't involve bone. Nasolabial cyst doesn't involve bone. Next, signs of human papillomavirus in oral cavity. The oral human papillomavirus is type 16. The anogenital condyloma acuminatum strongly linked to human papillomavirus 6 and 11, probably sexually transmitted, but in oral cavity 16. Next, odontogenic keratocyst, basal cell nevus, also known as Gorlin syndrome. Gorlin syndrome will have odontogenic keratocysts and basal cell nevus. So, reading from medbullets.com, we're going to read a little bit about human papillomavirus. In oral cavity, the human papillomavirus will be type 16. Well, in anogenital condyloma acuminatum, it's 6 and 11, strongly linked with 6 and 11. And they're probably sexually transmitted. So, in its classification, HPV is a virus. It's a DNA virus that is non-enveloped and is a papillomavirus. Its transmission is directly through contact and fomites. The reservoir is skin and genitals. As far as its molecular biology, there's multiple serotypes, more than 75. The serotype will determine which disease it is. Warts are hyperproliferations of keratinized squamous epithelium, and malignancy may result. So, again, warts are hyperproliferations of keratinized squamous epithelium. So, malignancy may result. There is an inactivation of tumor suppressor genes. So, in cutaneous wart, the serotypes are going to be 1, 2, and 4. Hands, fingers, and soles of feet. That is the serotypes 1, 2, and 4. Hands, fingers, and soles of feet. Anogenital warts, condylomata acuminata. Serotypes are 6 and 11. 90% of them are benign. So a coelocytes is going to be epithelial cells with structural Now the treatment: cryotherapy, electrocautery, salicylic acid chemical therapy, drugs like we will need to know the drugs. There is preventions to prevent against 16, 18, 6, and 11. This is a vaccine. The first vaccine is to prevent cancer. Untreated lesions may grow to the point of requiring surgical excision. Infections with serotypes 16 and 18 have a malignant potential. So that's about human papillomavirus, HPV, in which the type 16 is the orally involved. I'm not completely sure if the human papillomavirus orally is serotype 16. We're gonna check that pretty quick. Okay. So, yes, the genital warts are gonna be 6 and 11. The etiology of squamous cell carcinoma or external factors and are external factors and stress. Which factors are we talking about for squamous cell carcinoma? Has an etiology of squamous cell carcinoma: alcohol, tobacco, UV radiation, certain HPV types, vitamin deficiency, immunocompromised, iron deficiency, anemia, Plummer-Benson syndrome. Human papillomavirus 16 and 18, varicose leukoplakia. So just remember the condyloma accumulata are 6 and 11. 6 and 11. Okay, so we're gonna see now odontogenic keratocysts. Odontogenic keratocysts and basal cell nevus are Gorlin syndrome. So we're gonna do a quick search on Gorlin syndrome. Gorlin syndrome is known as the basal cell nevus syndrome. Basal cell nevus syndrome. And there will be seen a lot of odontogenic keratocysts seen. Gorlin syndrome, it's a nevoid basal cell carcinoma. Nevoid basal cell carcinoma, commonly seen odontogenic keratocysts and palmar pitting, plantar keratosis, odontogenic keratin cysts. So Gorlin, we'll see a little bit more of our Gorlin syndrome in board busters. So this will be in page 224 of Board Busters, and it's talking about odontogenic cysts, the nevoid basal cell carcinoma syndrome, which is also known as basal cell nevus bift rib syndrome, or Gorlin and Goltz syndrome. Gorlin and Goltz may present the following abnormalities. There will be cutaneous anomalies that include multiple basal cell carcinoma, other benign dermal cysts and tumors, palmar pitting, palmar and plantar keratosis, and dermal calcinosis. Again, cutaneous anomalies in Gorlin syndrome or nevoid basal cell carcinoma syndrome. There will be some cutaneous anomalies in which you will see multiple basal cell carcinomas, other benign dermal cysts and tumors, palmar pitting, palmar implantar keratosis, and dermal calcinosis. Another thing that you will find in dental are going to be dental inosis anomalies in patients with Gorlin and Gold's syndrome or nevoid basal cell carcinoma syndrome. In dental inosis anomalies in a patient with Gorlin syndrome, you will see odontogenic keratocysts, often multiple. You will see mild mandibular prognatism, rib anomalies, often biffed or bifed, or BIFED, and vertebral anomalies. Now, what you will find in nevoid basal cell carcinoma syndrome or Gorlin and Gold's syndrome, in eyes you will find hypertelorism with wide nasal bridge and congenital blindness. Also, you will find neurologic anomalies, which include mental retardation, dural calcification, agenesis of corpus callosum, and congenital hydrocephalus. Sexual anomalies in Gorlin syndrome is going to be hypogonadism and ovarian tumors in females. So, this is all on Gorlin syndrome. A typical question that you will find in Gorlin syndrome will be what is the most probable syndrome affecting a 9-year-old patient with a history of 3 keratocystic odontogenic tumors, OKCs. OKCs, multiple OKCs, and the answer is nevoid basal cell carcinoma syndrome, which is Gorlin syndrome. Again, the question says, what is the most probable syndrome affecting a 9-year-old patient with a history of 3 keratocysts odontogenic tumors? This is Gorlin syndrome, nevoid basal cell carcinoma syndrome. He has 3 OKCs. Highly likely that he will be having Gorlin syndrome. Another questions in different sources. It's going to be a patient that has cafe au lait spots. This will also be in Peutz-Jeghers syndromes, Albright syndrome, basal cell nevus bifid rib syndrome, which is Gorlin syndrome, Jeff syndrome, and neurofibromatosis. So the patient with cafe au lait will also have Gorlin syndrome. Patients with Gorlin syndrome will also have cafe au lait. Now, in which syndrome the patient has calcified falx cerebri, multiple OKCs and bifid ribs? Answer is Gorlin-Gold's syndrome, also known as basal cell bifid rib syndrome. Another question: what is hypertelorism? When the eyes are too far apart, and this is seen a lot in Down syndrome, Gorlin syndrome, and actually it's also seen in Crouzon's syndrome, and just a number of other syndromes, but Gorlin syndrome is one of them. Another question is Gorlin syndrome or basal nevus cell syndrome. Some characteristics about it, and bifid rib, and odontogenic keratocysts, and basal cell carcinoma. Okay. Now, in the DEX, you will find Gorlin syndrome also, and Gorlin syndrome. It's on the dental DEX in the oral pathology section, and the question is: a new patient walks into your office. Your initial physical assessment reveals that his eyes are set wide and that he has multiple lesions of the skin. When shaking his hand, you notice that the skin on his palm is very thick and has palmar pitting. When doing a health history, he reveals that he sees a neurologist and that he has some calcified structures in his brain. A panoramic radiography may likely reveal keratocystic odontogenic tumors, OKCs, because OKCs are seen in patients with Gorlin syndrome. Remember that patient we saw, that immigrant from Afghanistan? I believe he had Gorlin syndrome. He had some hypertelorism. He had what seemed to be some cutaneous anomalies. So a patient with the patient we were talking about in the dental deck, the new patient that has eyes that I said that are set wide and multiple lesions of skin, and when you shake his hand, you notice his skin on his palms are very thick and palmar pitting. The patient has nevoid basal cell carcinoma syndrome, which is also known as Gorlin syndrome. Is a disorder characterized by oral, systemic, and skeletal anomalies. It is an inherited group of defects that involve anomalies on the skin, eyes, nervous system, endocrine glands, and bones. The condition is characterized by unusual facial appearance and a predisposition for skin cancer. It is also known as the basal cell nevus bifid rib syndrome, the basal cell nevus syndrome, and the Gorlin-Goltz syndrome. Recently, mutations in the human homologue of Drosophila patched, a tumor suppressor gene, were identified as the underlying gene event in this syndrome. You will find anomalies in skin, so the cutaneous anomalies include multiple basal cell carcinomas, other benign dermal cysts and tumors, palmar pitting, palmar and plantar keratosis, and dermal calcinosis, dental and osseous anomalies including OKCs, mild mandibular prognathism, rib anomalies, often bifid, and vertebral anomalies. In the ophthalmic anomalies, you will find hypertelorism with wide basal nasal bridge and congenital blindness. Neurologic anomalies will include mental retardation, dural calcification, agenesis of corpus callosum, congenital hydrocephalus. In sexual anomalies, you will have hypogonadism in males and ovarian tumors in females. In the radiographic features, you will have calcification of falx cerebri, presence of OKCs. There's two more places in the pathology decks in which you will find an option of Gorlin syndrome. But, okay, never mind, we're not going to review that. In Dental Secrets, they talk about Gorlin syndrome. And one of the questions is, which odontogenic tumor is associated with amyloid production with ghost cells? Well, no, I'm sorry, this is Gorlin cyst, so forget about that. And okay, there's a pathology booklet in which you will see some images of Gorlin syndrome, and it's mostly odontogenic keratocysts, OKCs, that you will find. because OKCs are commonly known as Gorlin. So just remember that in neurofibromatosis, in Gorlin syndrome or calcific odontogenics, you'll find calcific. Uh, yeah, never mind. I was talking about something else. Okay, we're gonna go to the. Remember, hypertelorism, cleft lip sometimes, rib anomalies, bilamellar calcifications of falx cerebri, palmar pits, multiple basal carcinomas of skin, odontogenic keratocyst, most common finding, multiple lesions in mandible, young age, about 19-year-old, ovarian fibromas. All these are part of OKC, of Gorlin syndrome. The patient, the typical, okay, never mind. We're gonna go to the next question now. A patient is going to get a crown, but they want bleaching. What is the sequence? The answer is bleaching is always the first step, and then restoration is matched to the lightest shade. So, for bleaching, you will have H2O2 at less than 10%. Superoxide, 3% is used in office bleaching. Carbamide peroxide at 15 or 18% is straight bleaching commercially available in syringes. Carbamide peroxide, 15 to 18. Carbamide peroxide is a material used for mouth guard with vital bleaching. Carbamide peroxide at 10%. So, so a patient that has porcelain fused to metal on number 9 and complains that the porcelain fused to metal is lighter than the other teeth. What can you do? Change the porcelain fused metal or bleach teeth. When will you bleach teeth in anterior veneer prep? Before veneer prep, wait for 2 to 3 weeks, and then because the bleaching affects both enamel and dentin. So bleach first and then do the veneer prep. In office bleaching changes the shade through all except surface demineralization. For internal bleaching, it's used sodium perborate and 10% carbamide peroxide. Bleaching patient gets 21% home bleaching. This is wrong. It's 10%. Okay. The current home bleaching technique employing a custom fit tray containing 10% of carbamide peroxide solution. 10% of carbamide, not 25, 10% of carbamide peroxide solution was first used by in the 60s. The materials for office bleaching are usually supplied in concentrations of 35% hydrogen peroxide, although some concentrations may be as high as 50%. The caustic nature of 35 to 50% hydrogen peroxide mandates that soft tissues need to be isolated from any possible contact with the bleaching material. As an endnote, the intracoronal bleaching is with sodium permanate, which is walking bleach. Sodium permanate walking bleach, not hydrogen peroxide. Okay, superoxole is used to be used and contained 30% hydrogen peroxide, but the complication was external cervical resorption because of irritation, because it diffuses through the tubules to cementum and periodontal ligament. That was superoxole. Heat combined with it may cause necrosis of the cementum and periodontal ligament. This is found in Mosby, page 27. So, the current home bleaching technique employing a custom fit tray containing 10% of carbamide peroxide solution was introduced in the 60s. So, in-office materials are used primarily, usually supplied in concentrations of 35% hydrogen peroxide, although some concentrations may be as high as 50%. The caustic nature of 35 to 50% hydrogen peroxide mandates that the soft tissue be isolated from possible contact with the bleaching material. In endo, the walking bleach is sodium permanate and is intracoronal bleaching, sodium permanate. Sodium permanate, think about an endo doctor that eats a lot of salt. Sodium permanate. Dr. Susano eats a lot of salt and he likes el PRI. So permanent, sodium and permanent, Dr. Susano, walking bleach. Superoxole is not used anymore. It contained 30% hydrogen peroxide, but the complication was the external resorption because of irritation. It diffused through tubules to cementum and PDL. A patient that has a 25% bleaching and has increased its sensitivity. What is the answer, true or false? The first part is false, because the patient that goes home with bleaching is 10% and not 25%. So the question goes, patient got a 25% bleaching and has increased sensitivity. The first part is false because home bleaching is 10%. How soon after bleaching can you do a restoration? The optimal time to wait after bleaching is 2 to 3 weeks. That is the optimal, that is the best standard. 3 is standard or more even. Okay, that's in dental decks. How long after bleaching can you do a restoration? 3 weeks or more. Again, dental decks. A recent bleaching procedure, wait 1 week after bleaching, according to dental decks also. The question repeated again. The patient gets 25% home bleaching. This is wrong. It's 10%. But the second part is true. The second part says that he's having sensitivity. Okay. So, next question. And I'm gonna do a note on my calendar because I need to read the A must section. That's a really good file, so make sure you go back to it. So, we're gonna talk about oral signs of Addison's disease. So, in oral signs of Addison's disease, adrenal insufficiency has a symptom of hypoglycemia, not hypertension. So, primary adrenal insufficiency, which is known as Addison's disease, and that's the correct name, produces signs and symptoms that relate to a deficit of aldosterone and cortisol. The most common complaints are weakness, fatigue, and abnormal pigmentation of the skin and mucous membranes. Hypotension, anorexia, and weight loss are additional common findings. So, Addison, again, these are, it's a primary adrenal insufficiency. It produces signs and symptoms that relate to deficiency of aldosterone and cortisol. So think about Addison Aldo, that very skinny guy in secundaria. Aldo, he was very skinny. He had weakness, fatigue, abnormal pigmentation of the skin and mucous membranes, hypotension, anorexia, and weight loss are additional common findings. If a patient with Addison's disease is challenged by stress being illness, infection, or surgery, an adrenal crisis may be precipitated. This medical emergency manifests as severe exacerbation of the patient's condition, including sunken eyes, profuse sweating, hypotension, weak pulse, cyanosis, nausea, vomiting, weakness, headache, dehydration, fever, dyspnea, myalgias, arthralgia, hyponatremia, and eosinophilia. If not treated rapidly, the patient may develop hypothermia, severe hypotension, hypoglycemia, and circulatory collapse that can result in death. So this is all Addison's disease, oral signs of Addison's disease in a patient with hypoadrenocorticism, which are low adrenal corticosteroids, because of the destruction of adrenal cortex. There will be some diffuse melanin pigmentation in floor of mouth, ventral surface of tongue, usually the first sign of Addison's. Later, the bronzing of the skin can occur, usually in sun-exposed areas. So, Addison's disease is very important to review. and we're gonna see some questions about it. Addison's disease. In the Dentin NBD Part 2 book, we find that Addison's disease and Albright syndrome is a differential diagnosis of Peutz-Jeghers syndrome when there is oral pigmentations. But remember that Peutz-Jeghers has a different etiology and presentation, but they do share some clinical similarities, but we'll see that later. Addison's disease is a chronic adrenocortical insufficiency or hypocorticolism. It's a rare endocrine disorder caused by adrenal cortex hypofunction of cortisol, which is a glucocorticoid. So, if there's low glucose, remember, sugar is going to be low. So there is no enough cortisol being produced. The hyposecretion is either due to an adrenal gland disorder, which is known as primary adrenal insufficiency, or the inadequate secretion of ACTH by the pituitary. So ACTH is adrenocorticotropic hormone, and this will stimulate the secretion of cortisol, of glucocorticoids. So this lack of ACTH in the body to stimulate glucocorticoid production is called a secondary. The primary is because of adrenal gland disorder, and the secondary is because ACTH in the pituitary gland not being secreted or not being formed. Now, Addison's disease, this causes a bronzing of the entire skin. The cortisol is the most important function. Cortisol's most important function is to help the body respond to stress. That's why you will have problems with the patient that you're gonna have for surgery, because that's his stress mechanism. So Addison's disease is challenged by stress, illness, infection, surgery, and it can elicit a adrenal crisis. So it occurs in all ages, affecting men and women equally. The main dental concern during dental procedures is the patient with adrenal cortex has no capacity to produce extra cortisol in response to stress, which may result in Addison's crisis. What are the clinical signs? Usually start gradually and include weight loss, loss of appetite, muscle weakness, low blood pressure, hyperpigmentation of the skin in both exposed and unexposed parts of the body, most visible on scars, skin folds, pressure points like elbows and knees, knuckles, toes, and oral mucous membranes. They also cause nausea, vomiting, and diarrhea. The oral signs of Addison's disease is going to be a diffuse pigmentation of the gingiva, tongue, hard palate, and buccal mucosa. Although cutaneous pigmentation will usually disappear after therapy, the pigmentation in the oral tissues persists. The lab tests for Addison's disease show low blood concentrations of sodium, because remember that that was one of the important things that you mentioned is hyponatremia, low glucose, and increased potassium, serum potassium, and decreased urinary output of certain steroids. So, Addison's disease is counted as one of the factors that can cause orthostatic hypotension. Orthostatic hypotension is a postural hypotension, abnormally low blood pressure occurring in individuals as they assume the standing posture. After vasovagal syncope, orthostatic hypotension is the second most likely cause of transient unconsciousness in the dental office. So after vasovagal syncope, the orthostatic hypotension is the second most likely cause of transient unconsciousness in the dental office. The factors that can cause orthostatic hypotension are administration of ingestion of drugs, prolonged recumbency and convalescence, an inadequate postural reflex, pregnancy, defects in legs, various defects in legs, and Addison's disease. There will also be starvation, chronic orthostatic hypotension, which is a Shy-Dragger syndrome, and physical exhaustion. The incidence of orthostatic hypotension increases with age. Non-steroidal anti-inflammatories are not known to produce orthostatic hypotension as an adverse defect. So Addison's disease is one of the reasons why you will see commonly orthostatic hypotension. And where are you going to see this in Addison's disease? Because Addison's disease is in charge of we have weakness and fatigue, and well, that's all you need to know for now. So the corticosteroids are hormones that are produced in the adrenal cortex that do not cure any disease, but they represent placement only on Addison's disease. Corticosteroids treat asthma, arthritis, if patient has peptic ulcer disease, and do not use, but corticosteroids should not be used for arthritis. So corticosteroids can treat also allergic reactions, Addison's disease, lupus, aphthous stomatitis, and TMJ pain. Corticosteroids contain of two groups, the mineralocorticoids and the glucocorticoids. So the mineralocorticoids will be all those in charge of regulation of sodium and potassium reabsorption in the kidneys collecting tubules. These mineralocorticoids are aldosterone and the most important one, and I don't know if there's more, I have to think about it, but aldosterone is a major natural mineralocorticoid in humans, secreted by cells in zona glomerulosa of the adrenal cortex. Remember, the adrenal cortex has three layers: GFR, granulomatous, fasciculata, and reticular. Okay, so the glomerulosa is the most external, and that is the cortex of the adrenal gland. So aldosterone secretion is regulated by ACTH, which is produced in the pituitary gland. In which part of the pituitary gland? In the I don't remember. I think it's in the posterior, maybe. Anyway, aldosterone secretion is regulated by ACTH and the renin-angiotensin system, and is very important in regulating blood volume and blood pressure, and promotes sodium reabsorption into the blood from the glomerular filtrate. Potassium is lost in urine because of the electronegativity negativity created by the resorption of sodium in the kidney tubules. Increased blood aldosterone levels result in high sodium and low potassium levels in plasma. So, when there's a decreased sodium concentration causes the juxtaglomerular cells of the kidneys to secrete renin, which converts angiotensinogen in angiotensin 1. This is in the lungs. Angiotensin 1 is converted into angiotensin 2, which then stimulates the adrenal gland to release aldosterone. And this is the other way that adrenal gland is controlled by, and this is by low sodium. So low sodium stimulates the juxtaglomerular cells to produce renin, and renin transform angiotensinogen into angiotensin 2. Then angiotensin 1. Then angiotensin 1 is converted into angiotensin 2, which stimulates the adrenal gland to release more aldosterone. And aldosterone will be secreted, and it will regulate the blood volume and blood pressure by promoting sodium reabsorption into the blood. So now in Addison's disease, which is what we were talking about, there will be Addison's disease will be caused by hypotension. So that's why you will have hyponatremia and low blood pressure in patients with Addison's disease, because there's no sodium being collected, reabsorbed to the blood. So Addison's disease caused by hyposecretion of aldosterone and cortisol. For adrenal crisis, the treatment for adrenal crisis, and this is important, adrenal crisis treatment, treat with 2 milligrams of hydrocortisone. The corticosteroids represent replacement only in Addison's disease. So that's the only time when a corticosteroid will be given in a constant manner in Addison's disease. Now, other parts to study about aldosterone, which is the mineralocorticoid, is ADH, which is a vasopressin. ADH decreases urine production by increasing water reabsorption by the renal tubules, which it increases the permeability of the collecting ducts and distal tubules. Without ADH or vasopressin, there would be extreme water loss into the urine. At high concentrations, ADH causes arterioles to constrict. Other mineralocorticoids are deoxycorticosterone and fludrocortisone, but all we want to study right now is really aldosterone. Now, the glucocorticoids, they have important effects on the carbohydrate, lipid, and protein metabolism. That's why there's going to be wasting of muscle and weakness, and also they're going to be very skinny and a patient with Addison's disease, because there is no secretion of corticosteroids. Okay, corticosteroids meaning both mineralocorticoids and glucocorticoids. So there's going to be catabolism. There's going to be changes in immune responses and inflammation. The majority of anti-inflammatory and immunosuppressive actions of the glucocorticoids are the result of their action on the arachidonic acid metabolism. They induce the synthesis of a protein that inhibits phospholipase. Again, induce the synthesis of a protein that inhibits phospholipase A2, which decreases production of prostaglandins and leukotrienes. So that's why it is used, glucocorticoids are used a lot, because they have a anti-inflammatory and immunosuppressive actions of the glucocorticoid, which are a result of their action in the arachidonic acid metabolism. They induce the synthesis of a protein that inhibits phospholipase A2, which decreases the production of prostaglandins and leukotrienes. Now, cortisol is the major glucocorticoid that treats Addison's disease. Cortisol, which is hydrocortisone. Now, synthetic glucocorticoids like prednisolone, methylprednisolone, dexamethasone, and triamcinolone are synthetic glucocorticoids. Now, there is also inhaled glucocorticoids, which are beclomethasone, budesonide, flunisolide, and they are developed to treat chronic asthma and bronchial disease by rapidly penetrating the airway mucosa, but very short half-lives. But they have very short half-lives after they enter the blood, so systemic effects and toxicity are reduced greatly. Now, fluticasone, which is a corticosteroid administered by the inhalation to asthma and decreasing the inflammation of the airway, has been reduced. Well, that's a lot of stuff that we're not going to get into right now, because we're studying Addison's disease, and this is very important, but it's not what we need to study right now. So anyway, that was a really good review. We are going to go back now to study the next subject, and it says, after flap surgery, how does the tissue heal? After flap surgery, how does the tissue heal? And it says long junctional epithelium. Only GTR does long junctional epithelium not occur, and is by the actual movement of osteocytes movement from the periodontal ligament to the area. So after a flap surgery, how does the tissue heal? So according to this, is by the actual movement of osteocytes from the periodontal ligament to the area. So flap surgery, we're going to study some of that. Chapter 7. So we're going to read a little bit about flaps. So an autogenous free gingival graft is an autogenous graft of gingiva placed on a viable connective tissue bed where initially buccal or labial mucosa were present. Usually the donor side from where the graft is taken is an edentulous region or palatal area. The graft, the autogenous free gingival graft, The graft epithelium undergoes degeneration after it is placed, then slows. The epithelium is reconstructed in about 1 week by the adjacent epithelium and proliferation of surviving donor basal cells. In 2 weeks, the tissue reforms, but maturation is not complete until 10 to 16 weeks. The healing time required is proportional to the graft's thickness. The greater amount of shrinkage will occur within the first 6 weeks. Now, that was an autogenous free gingival graft. A free gingival graft involves removing a section of attached gingiva from another area of the mouth, usually hard palate or anadentalus region, and suturing it to the recipient site. Free gingival graft success depends on the graft being immobilized at the recipient site. A free gingival graft is used to increase the zone of attached gingiva and possibility of gaining root coverage. The difficulty is in getting complete root coverage lies in the fact that an avascular graft is placed over a root surface also devoid of blood supply. So this is the hard part, because you get your free gingival graft, which is separated from blood supply, and you put it in a place where it will have a big wall of non-irrigated tissue, which is the tooth, the cervical area of a tooth. Free gingival graft retains none of its own blood supply and is totally dependent on the bed of recipient blood vessels. So a free gingival graft retains none of its own blood supply and is totally dependent on the bed of recipient blood vessels. The free gingival graft receives its nutrients from the viable connective tissue bed. The main reason a free gingival graft fails is disruption of the vascular supply before engraftment. Infection is the second most common failure on a free gingival graft treatment. Free gingival graft indications: to prevent further recession and successfully widen the attached gingiva, you will use a free gingival graft. Indications also for free gingival graft is to cover non-pathologic dehiscences and fenestrations. If performed with a frenectomy to prevent formation of high frenal attachments. So you can do a frenectomy and place a free gingival graft on top, distal to the apex of the frenum. You can use also free gingival graft to cover a root surface with a narrow denudation. Free gingival graft may or may not yield a successful result when used to obtain root coverage. The result is not highly predictable in root coverage cases. Used therapeutically to widen attached gingiva after recession occurs, and to prophylactically prevent recession where the band of attached gingiva is narrow and of a thin, delicate consistency. So it can be used therapeutically to widen attached gingiva after recession, and to prophylactically prevent recession where the band of attached gingiva is very narrow and you know that it's going to be lost. The current localized narrow recession or clefts. But not deep wide recessions. Deep wide recessions are not going to be an indication for free gingival grafts. Okay, in such cases, the laterally repositioned flap, which is a pedicle flap, has a greater predictability because this position flap retains some of its blood supply. Free gingival grafts are rarely used on facial or lingual surfaces or mandibular third molars, especially facially. Free gingival graft healing involves revascularization of the graft. The graft's top layers are revascularized last. Thus, the epithelium dies off and degenerates, producing a necrotic slough. During healing, the epithelium of the free gingival graft degenerates, and it's a necrotic slough, and re-epithelialization occurs by proliferation of epithelial cells from adjacent tissue and surviving basal cells of the graft tissue. Now, this is a free gingival graft. Now, it's different than a free mucosal graft, because a free mucosal graft, we're going to talk about it now, it differs that the transplant is connective tissue without an epithelial covering. We're going to go deeper into this. The epithelial differentiation is induced by the underlying connective tissue, so that free grafts of dense connective tissue taken from keratinized areas result in the formation of keratinized tissue even when transplanted to non-keratinized zones. So this procedure is more difficult than the free gingival graft. It is often used in canines where little keratinized gingiva exists to create a band of gingiva-like tissue. So this is free mucosal graft is keratin. Again, free mucosal autograft is a graft that differs from the free gingival graft in that the transplant is connective tissue without epithelial covering. Okay, the epithelial differentiation is induced by the underlying connective tissue, so that free grafts of dense connective tissue taken from keratinized areas result in the formation of keratinized tissue when transplanted. During healing, the epithelium of free gingival graft degenerates and it creates a necrotic slough. And re-epithelialization occurs by proliferation of epithelial cells from the adjacent tissue and surviving basal cells of the graft tissue. Now, we're going to talk about root amputation and hemisection, which they need to be done in conjunction with endodontic therapy of a tooth. Endodontic therapy is performed first, followed by periodontal therapy. Root amputations is the separation of individual root from the crown. Most times, these teeth are going to be maxillary first and second molars, commonly involved because they're commonly involved periodontal sites. Burrs and diamond stones are used to sever the crown and root before extracting by root tip forceps. Once the root amputation is complete, the remaining apical area of the crown and furcation region are recontoured similar to the shape of a pontic, so maximal access is provided for oral hygiene. The hemisection is the vertical sectioning of a tooth through both the crown and root. Usually, a hemisection is used in a mandibular molar region, where the crown is divided through the bifurcation region. 50% of the tooth is extracted if one specific root has excessive loss in osseous support, and the remaining half of the molar tooth is now treated as a premolar. Okay. Now, a distal wedge flap or proximal wedge is the simplest distal flap procedure approach used for retromolar reduction. This procedure is often performed after wisdom teeth are extracted. Because the bone fill is usually poor, leaving a periodontal defect, this region is occupied by glandular and adipose tissue covered in an attached non-keratinized mucosa. Only if sufficient space exists distal to the last molar, a band of attached gingiva may be present. In this case, a distal wedge operation can be performed. This is a distal wedge. Distal wedge flaps are performed in these areas: maxillar tuberosity region, mandibular retromolar triangle area, and distal to the last tooth in the arch, or mesial to a tooth that approximates an edentulous area. Many designs have been presented for the distal wedge flap procedure. However, the basic concept involves making at least 2 incisions distal or mesial to the tooth and carrying these incisions parallel to the outer gingival wall to form a wedge. The wedge base is the periosteum overlying the bone, and apex is the coronal gingival surface. Detaching the wedge from the periosteal base eliminating involved tissues in the distal pocket region reduces the tissue bulk and allows access to the underlying bone. And we're going to continue reading flaps because that's where we are right now, and we still have a lot to see. But it's been an hour, so I'm going to start a new video.